In this right elbow in the prone position, the bayonet technique for release of the ECRB is accomplished with a 30-degree arthroscope in the proximal anteromedial portal. A spinal needle is advanced into the joint anterolaterally and immediately adjacent to the lateral epicondyle to confirm position and orientation of a tennis elbow portal. Using this spinal needle as a guide, a number 15 scalpel blade on a handle is advanced blindly in a controlled sweeping motion, thus releasing the ECRB origin as the knife is advanced. Knife blade advancement is continued until all of the ECRB tendon is sharply released from its origin on the lateral epicondyle. While inside the elbow joint, the knife blade is rotated and a limited capsulotomy and incision through the superior margin of the ECRB tendon is performed as shown. Beyond the ECRB tendon are the muscle fibers of the ECRL, noted here. Next, the scalpel blade is redirected to the inferior aspect of the ECRB tendon and a separate incision through the capsule and inferior ECRB margin is carried out, taking care to limit the inferior extent of this incision to the radiocapitellar joint midline or equator, so as to avoid inadvertent injury to the lateral collateral ligament complex. An arthroscopic shaver is then used to resect the released pathologic ECRB tissue for approximately 1 centimeter, as shown here. Next, the shaver is redirected toward the origin of the ECRB at the lateral epicondyle, where any retained ECRB tendon and other soft tissue is debrided. During this and any elbow arthroscopic procedure, care is taken to maintain the visualization of the arthroscopic instruments and orientation at all times. Additionally, light abrasion of the lateral epicondyle is also carried out, as shown here, in an effort to stimulate a healing response. Following this debridement of the ECRB tendon and lateral epicondylar origin, the bayonet technique for arthroscopic lateral epicondylitis release is completed. Assessment of the ECRB release is accomplished using a probe palpating the resected edge of the ECRB tendon and the muscle fibers of the ECRL. Note here that the probe demonstrates that limiting soft tissue release to the midline of the radiocapitellar joint has been respected, thus protecting the lateral collateral ligament complex located more inferiorly. Finally, the debrided and lightly abraded lateral epicondyle is visualized.